Recording in progress.
Just giving it 1 second, everyone, letting everyone finish joining. Sorry, just making sure we've got everybody here. Okay. All right, well, good morning, everyone. Lovely to see you all. Thank you for being here on a Monday morning in May. There we go. There's my alliteration for the day. So yeah, good to see you. My name is Kimberly Lang. I am a senior specialist for member programs and services here with the First Nations Health Directors Association. I'm just going to give a little shout out to Shaylia, who is our member services coordinator, who is also here with me from Team FNHDA. So lovely to see you all. And yeah, also want to acknowledge all of the beautiful territories from which we are all joining across the province today. I'm down here on Tsleil-Waututh territory on top of Burnaby Mountain, where it is cloudy, but there's like little hints of blue sky between the clouds. So kind of typical May weather. So yeah, great to see you all. And thank you for being here. And on a Monday. So sorry, I'm a little distracted because people keep on jumping in the waiting room and I keep trying to let everybody in. So you know what I'm going to do is I'm going to pass it to Megan and Emma, who are going to be leading the webinar, and we'll see you all along the way. Over to you, Megan.
Marcy, thank you, Kimberly. And Balmachan, good morning, everyone. Megan Dishnakashan. My name is Megan Amachipnia. I am Métis on my father's side from Treaty 1, the Red River, and the North Dakota Turtle Mountain Territory. And I am so happy to be here with everyone this morning. I serve as the Communicable Disease Emergency Nurse Advisor with the CD team at First Nations Health Authority. And I'm joining today from the unceded traditional territory of the Syilx Okanagan peoples, where I am so grateful to live as a guest and where I was born and raised here. And so with that, I'm going to let Emma introduce herself, and then we're going to get started with our presentation.
Good morning, everyone. My name is Emma Leon, and I'm a communicable disease nurse coordinator on the same team as Megan. And I am calling in from the traditional Nakaslii territory in Fort St. James. And I'm really happy to be here with you guys and excited to journey through our presentation together.
Wonderful. And as you'll see on the screen here, the focus of today is going to be on measles. And we're going to try to do a real deep dive into measles and also talk about the things that we can do to help prepare and prevent measles from coming to our communities. And so before we get there, I'm just going to also acknowledge that typically FNHA operates on Squamish, Musqueam, Tsleil-Waututh territories, and grateful to them and to the territories and to the stewardship there. And so wanting to acknowledge that. But really, what we're here to talk about today is, again, measles, and maybe why we've been a little bit concerned about measles, and maybe why we all need to pay a little bit extra attention to measles right now, and also inform what we can do about it. And so, as I said, you may or may not have been hearing about measles. There has been reports of measles in the news. There's been concerns of cases and outbreaks and even deaths in some places with measles. And I think it's important to acknowledge that in British Columbia, measles is not typically talked about as much as it is right now. It's historically been a rare disease for the past at least 25 years. And this is really owed to a successful what's called elimination of measles. And so in 1996 era to 1998, they did this big immunization campaign. And so they really focused on immunizing a lot of the population in British Columbia. and that was really successful. There was a high percentage of people who did get that vaccine, and then it caused measles to not circulate in BC anymore. And so we still did see occasional cases of measles when people who were unvaccinated would travel to places where measles was circulating more frequently, and then brought it back, of course, to BC because of our interconnected world. But we really haven't seen a lot of it since elimination happened. And this happened in Canada in 1998. And so really, those measles cases that are coming back from these places where measles is circulating, this is called importation. And that's really what we've been seeing over the past 25 years is these kind of more rare, infrequent importation cases of measles, not widespread as it is today, right now. And so because we live in this connected world and this transmission is happening occasionally, um, this increased importation is really, we think, caused by generally lower immunization rates due to impacts from COVID-19 and from otherwise. And there's been places all around us, which we're going to talk about, who have experienced much higher numbers of measles this specific year because of that. And so we're going to talk about all of the factors around that and then some of the things that we can do. But one of the things that I do want to point out at the beginning here is most of the cases, doesn't matter where we're looking, whether it's in Alberta or Saskatchewan or Ontario or in the US, most of the cases have been in children and adolescents. And measles really is so contagious and it can have some devastating impacts. And so that's what we're here to talk about today. That's why we're a little bit concerned. And we'll jump right into it now, into some of the numbers around this, what's going on in this situation. And so, as I said, the situation is kind of growing all around us. In Alberta, the most recent case numbers have gone up to 326 cases as of this Monday morning that I saw. And again, most in children and adolescents. In Ontario is another place that they're experiencing a large outbreak where we're seeing 1,440 measles cases, and most of those, again, were in children and adolescents. And in the US, again, 1,001 cases. That was as of Friday. And they've also seen 3 deaths from measles in their population, and 68% were in children and adolescents.
At
Oh.
2:25, it's a direct flight, and it gets in at 17:35.
So these infected cases in people are really telling a story in which we've heard about measles, but we may not remember. And that is, measles is really contagious and dangerous. It is said with every person who gets measles, they can infect about 9 out of 10 other susceptible people. And about 1 in 10 people who get measles will be hospitalized. And so we're going to kind of look at that in comparison to other years as well, and what we're seeing in BC here. And so we have not seen any cases in BC First Nations communities that we've seen yet, but we have seen a few cases in BC. And so if we look at these numbers here in 2024 and 2025, you actually can't even see BC's numbers because there's so few. Last year, we had 1 case of measles in BC. This year, we're up to 8. And the cases have been a mix. They've been in Fraser Health Authority and in Vancouver Coastal Health Authority, and they've all been related to travel. And then if we look at the Canadian cases, we had not too many last year, less than, I think it's about 150 last year. I can't see the number right here, but as we know,
Okay,
as I
well, you
said,
do that, and
oh,
See if there's a hotel room.
and then this year it's looking up to, we're getting close, and this actually is probably an older number. We're probably up beyond 1,500 cases this year. And so that is actually the most cases in Canada that we've seen since elimination back in 1998 in a single year. And we're only 5 months in. And then again in the US, you can see that there was significantly less cases last year of measles than there are this year. And so, as I said, take my numbers with a small grain of salt, but we do know that this situation is growing, and it's the worst it's been in quite a few years. And so, again, while it's important, there is some variation between some of these places, it's important to note that really, no matter where we're zoomed in or zoomed out to, most of these cases are in children or adolescents, and most are unimmunized or have an unknown immunization status. And as I kind of mentioned before, we kind of have some inklings as to why that is. And so we know that this is a highly contagious virus. We know that mostly affecting children and adolescents, and there's these what we call pockets of risk or vulnerability that we need to pay attention to. And what these numbers on the screen are showing us is our immunization coverage rate for measles. And this is data from 2023, and this is provincial data. And so it's for 2023, this number is for 2-year-olds. We had 81.7% of our 2-year-olds vaccinated on average in BC. And then this is the number for 7-year-olds, which we had 72.4 percent of our population of 7-year-olds vaccinated for measles. And so this kind of starts to tell us a story. And there's some people who are kind of looking at this at all the levels, and they're thinking, we think that many people probably missed opportunities to get vaccinated during COVID-19, and whether that was their second dose, which it does kind of look like with the 7-year-old population here, because we know first doses normally happen around 12 months and second doses normally happen around kindergarten age, so 4 to 6. And so we think that there may have been that population missing their immunizations during COVID. And then there's been lots of work, of course, to try to catch people up after that. But we know that there's probably some more work that we can do around that. And so, and I just wanted to note at this point that this is not obviously First Nations specific data. That is protected under OCAP. But if community health nurses or people in the health center do want to request or try to figure out who in the population is missing their measles vaccine, we do have a team. The clinical informatics team can help people with that. And we've been also messaging the nurses about that as well. And so just so you know, we do have kind of ways of looking into who's maybe missing vaccines, but that does seem to be one of the main issues in general in this situation. Because we know immunization is the best protection against measles. For children, and for most adults born in 1970, this means born in or after 1970, sorry, this means that receiving 2 doses of measles vaccine will give you protection. And so it's really highly protective as well. In fact, after 2 doses, you're almost 100% protected against measles, lifelong protection. And really connecting this to our current situation, as we've been seeing the outbreaks, there's a risk of outbreak is highest when a person who is unvaccinated or non-immune travels to an area or a country where measles is circulating, they get infected, and then they bring it back, and really, if they bring it back to an area or they get connected where there is maybe a group of people who are unvaccinated or non-immune clustered together, that's where we're seeing the biggest risk of outbreaks, as measles, again, is one of the most contagious diseases. And although vaccination rates in Canada are generally high, they are below what is needed for what's called community immunity or herd immunity, you may have heard. And so what that relates to and what that means is that there's different kind of numbers calculated with different diseases depending on how infectious they are. And for measles, we know that we need about 95% of people vaccinated for measles to be able to stop prevention and to stop transmission. And so that we know that those numbers are below that. And when we looked at those numbers from 2023, we saw between 70 and 80% vaccinated. And so we know that there is increased risk where we are, and to pay attention to that. And these are kind of some of our thoughts about some things that we can do to help prepare and to prevent measles. But before we kind of get into that, we just want to acknowledge that we know that there's a long and painful history among First Nations people and lots of harms done from communicable diseases themselves, but also from responses from healthcare professionals and other entities and systems that really layered onto that. And so we want to be thoughtful in our approach and recognize that every community is self-determining and sovereign and carries their own historical context and what's best for the people. And so we really do honor and respect that. And we just want to humbly acknowledge that maybe these are some things that might connect with you, that might click with the community, that you may want to think about doing in the coming weeks to prepare for potential measles cases. And so that includes staying informed. So we're going to talk a little bit more about measles infection and what that looks like and kind of putting that out in different ways that we can communicate that. We also want to support immunization. We want to communicate resources. We want to stop spreads of infection, and we want to basically come up with an infection control plan around measles. We want people to review their community plan for infection control and for emergency preparedness. And we are hoping to also give you some context about how to care for measles in the community as well. And so with that, I'm going to hand it over to Emma for the next few slides, and then she'll hand it back to me.
So the next slide is just talking about where you can find measles updates at the source. This can be something that you do yourself as a health director, or it can be something that you task your community health nurse with and say, like, once a week, can you look at these sites? Can you give us an update at the increases? However it works within your health center, your nursing station, that's good. We just want to let you know what's out there for information. We do release information from First Nations Health Authority. BC CDC has a measles page that they've changed in the last few weeks that includes updates on the cases local to British Columbia. So it's not broken down further than British Columbia, but it does tell us what's going on in the province. And then nationally, we have the Canadian Measles and Rubella Weekly Monitoring. So that's where you're going to see everything for the whole country. And that is broken down into provinces there. So you can see where it's increasing and what's happening. And it is a good idea just to keep a little bit of awareness to that, even though right now it feels like, oh,
Candice,
BC
you should get
BC only has 8 cases. But it's still good to know where it's at and to be able to talk to the community when you're out and about, when you're having interactions and people are asking, like, how serious is this for us? What do we need to know? You're able to say, like, yeah, I just looked at the new updates from this week, and BC's still looking good, or BC's not looking so good anymore, and we really need to increase vaccinations, or whatever your conversations are. That can be a good solid foundation to have that knowledge moving forward. And then the next thing to know is, what is measles? Some of you may be of the age that you had measles yourself, or you had family members that had measles, and some of you may not have. Some of you may be of the vaccinated age, and so maybe that wasn't your lived reality, and you've only had people sharing their stories about measles, and you haven't actually seen it. So measles is an infectious disease caused by the measles virus. It's very contagious, and it spreads easily through the air. And that is something that will often be called airborne. Those two words can be used interchangeably, and that means that it spreads through coughing and sneezing, and then also on surfaces. While there are people protected from measles, people without immunity will get and spread it easily. For every 1 infected person that measles infects, that person can give it to 12 to 18 people if they don't have immunity. So that means if they haven't been vaccinated or they haven't had measles themselves, 12 to 18 of those people could get sick. And that's a really high rate in comparison to something like COVID. You remember that COVID was stressful, everybody was worried about it. And I think, and Megan can correct me, I think COVID is around 5 people that it can infect. So this is more than double that rate if people aren't protected. Symptoms of measles that are good to be aware of is a high fever over 38.3 degrees Celsius, a cough, runny nose, and red eyes. And the key here is that measles starts out looking like a common cold or a viral infection. And then what distinguishes it is then 3 to 7 days after the fever starts, a red blotchy rash will appear. The rash usually starts behind the ears and on the face and spreads down the body and then to the arms and legs. Symptoms usually start 8 to 12 days after you've been exposed, but it can take up to 21 days from the time that someone was in contact with with the virus to when they could become symptomatic. And someone who has measles can spread the disease to others starting a day or two before any symptoms develop. So being aware of what these are and why it's serious, because measles spreads easily. Measles virus can live in the air or on surfaces for up to 2 hours after the person has been in a room. So we're going to get more into this 2 hours thing later on, but just keep that in your mind because that's going to be important for your health center or your school or your band office. Those are important things to know. And there can be serious complications for people who have pneumonia, such as hearing loss and brain damage. Sorry, for people that have measles, they can have pneumonia, hearing loss, or brain damage. And hospitalization can occur in approximately 1 out of every 5 people infected. Before vaccines were developed in the 1960s, 3 million children died of measles around the world each year. In the pre-vaccination era, it was universal to get measles before the age of 15. As Megan already said, BC introduced a 2-dose measles vaccination program for children in 1996, and then Canada has been free of endemic measles since 1998. And measles was declared eliminated in the Americas in 2002. However, measles cases and outbreaks continue to occur in Canada due to periodic importation. And small declines in vaccination rates have huge impacts on transmission and outbreaks. And so one thing that we're looking at right now is that through COVID, the children that turned 4, 5, 6 through like 2020, 2021, 2022, that's where we're seeing a big decrease in the vaccination rates because health centers were closed. In some areas, people were frightened to go into health areas because they didn't want to contract COVID or they didn't want to risk their kids. And so there's been a delay in kids getting their vaccinations. So historically, if one child in a classroom were to contract measles, they may have measles and it would probably just fizzle out with them. Now, what the worry is that there could be classrooms that have maybe 10 unvaccinated kids in the classroom. And because measles spreads so easily, that could mean that all 10 of those kids get measles. And then they could bring it home to their cousins, their little babies, their siblings, if they have babies in their family, their elders, grandma, grandpa. And so what we're trying to do is protect our most vulnerable people. So that's why the whole message through this is immunization and figuring out who needs to be immunized. So supporting immunization and working on improving immunization rates in the community is one of our top priorities right now. And we've talked in some of our meetings that as much as we're not happy that we're in this situation, that measles is rearing its head and that, we'd rather not be spending all of this time talking about measles and learning more about it and educating people, but it's an amazing opportunity that we're having to say, hey, this is a thing, but it's actually not in our communities right now. Let's talk to our community members. Let's share with them the importance of vaccination and being able to have the time. Basically, we're given the gift of time right now to go through records, to make sure we have extra vaccines on hand and to give those doses. So a couple of the ways that you can do that is if you have nurses in your community, to have the conversations with them and to dedicate time to them to immunize the community members, to go through the records, to connect with those families. And if there isn't a nurse in the community that's able to immunize, then to make a plan with your nearest, if it's a nearest municipality that has a regional health authority, like public health location where they can get vaccinated, making sure that community members can go there easily. Maybe that looks like having some rides available, or if you have a community shuttle service, different communities have different things, but just supporting those efforts so that there's less barriers to getting those vaccinations done. And then encourage all your staff at your health center to check their measles immunization history. For all healthcare workers, assess all new employees born on or after January 1st, 1957 for proof of 2 live measles vaccinations. And your nurses are going to do this. This isn't a task for you as health directors to do. This is a task for your nurses to do. We're not asking you guys to suddenly be educated in the whole scope of immunization, but for you to just have an awareness of what this means. This is important because if a person is exposed to measles without these documented doses, they will be excluded and told to isolate and watch for symptoms, which means they won't be able to come to work for as long as the medical health officer says. And it's really important to have those people immunized or immune so that your health center and nursing stations can continue to run and you can continue to provide services to the community. So I'm not going to get too far into the weeds of this because this is something that your nurses are going to know and going to be able to assess. And if they can't, they're going to connect with our team or with the immunization team to go through this. But the people who are known to have measles protection have been born before 1970, which means that they've likely had measles as a child. They've maybe had lab confirmed measles. A blood test shows evidence of immunity to measles, or they have documentation of 2 doses of the measles vaccine. Should we be doing lab work to assess people's immunity to measles if someone is not sure? So this is something that your nurse can connect with the immunization team on, and they can specifically talk to that. There is a section in the BC CDC manual talking about this that goes through all of the details of doing lab work and not doing lab work and how that works out. And there was just one other comment here that I wanted to look at before we move on to the next section. We have received negative responses from community members who were contacted by our health nurse. They believe we breached confidentiality by accessing their immunization records. Can FNHA create a communique that states our CHNs are not breaching privacy laws? Yes, we can work with the CIS team that Megan talked about and look at creating something for this. So thank you for bringing that up. I will make a note of this. Shelly, can you pop your email address in underneath your comment, and then we can connect that back to you when we have that ready? All right. And so I will pass it back over to Megan now.
Thanks, Emma, and thanks everyone for the questions in the chat too. We're going to move forward here about communication resources. And so it's always important to communicate effectively with community members and leaders to raise awareness during emergencies and otherwise. And I think even some of the questions in the chat today are kind of bringing up some things that are important to communicate that. So thank you so much for bringing that forward to us. But really, we're not trying to reinvent the wheel with communication resources. We just want to say, like, use what works for you and your community already. Use Facebook, use the newsletter, use phone calls. And we really want to make sure that the information is accessible and it's relevant and it gives people something to do. Like, what's great about this, as Emma already kind of highlighted, is we actually can do something that would make a difference if measles came to our community, and that's we have vaccines and we have some other tools as well in our back pocket to make sure that this this doesn't create an emergency in the community. And so really using our voice, using our communication pathways to communicate what people can do to protect themselves and to protect their family members is going to be really, really important. And another thing I feel like is important that as public health people, maybe we didn't do the best job during COVID, but really addressing the uncertainty of this. While we have concerns from our team and from lots of other people in this space around measles, we don't know what's going to happen with measles. We could do all this preparedness and then it could never come to the community, and that would be a wonderful outcome. And if we increase preparedness in the meantime, that's great too. But we don't, the truth is, we don't know everything about what's going to happen, and kind of acknowledging that within our communications is going to be important as well, to not create fear, but to just allow people to be informed and to be aware. And so we do have a few posters for measles and a few more in the works too. And so that's really great. The first two there that you see, one of them's focused on immunizations, one of them is focused on measles illness themselves itself, and then one of them is focused on actually it's for health staff and just to be thinking about measles. It's got all the symptoms on there. It's got about what the kind of questions you want to ask in a pre-screening call. It's got the things to do for infection prevention and control if you do come across measles in the health center. And so that's a really good one to have as well. And we'll be sending these out in the email afterwards as well. And then the next step is going to be to kind of look at stopping the spread of infection. And part of that is coming up with an infection control plan. And some of this may be just kind of second nature to nurses and to the health center at some points, but this may put a different lens on it with measles as well. So I am going to kind of walk through a situation to kind of think about and get ourselves to think about what we can do to prevent and to include into our infection control plan. And so really, we do want to create that awareness in the community and even encourage people to call ahead to report symptoms if they think they may have contracted measles. If it does get to a point where it's spreading around the community or things like that, that's something that's going to be important, as well as posting signage in the health center about reporting signs and symptoms of fever, of cough, of any of those things, so that we can take those protective measures in the moment. Maybe we need to put them in a mask. Maybe we need to be putting on a mask. And that's all part of performing a point of care risk assessment, which nurses in the health center should be doing upon every interaction to make sure that they're protecting themselves and that the patient is protected as well, or the community member is protected. And so that's a really important piece. If they can be assessed over the phone beforehand, if it's possible to even see them outside rather than inside, it's a good idea. And if they do need to be seen in the clinic, to do so potentially at the end of the day rather than at the start of the day, and having them put on a mask and put into a private room, as well as making sure that the person going into that room, and really all healthcare workers in general, should be fit tested for an N95 mask, which is the type of mask that's going to prevent against any airborne transmission of measles. And so that is something that does need to be tested every year because our faces may change and we want to make sure that there's no leaks around the mask. So regardless of vaccination status, everyone who's caring for someone with potential measles should be wearing one of those masks. And if a person does arrive to the health center without calling ahead, really just ensuring that they're putting on a medical mask themselves. They don't need the N95 because they're not going to be fitted to that, but putting on some sort of mask and putting them into a private room will be a really, really good idea. You'll also notice that we have ventilation on here. And while I will not claim to be the ventilation expert, but
Okay, let me.
sorry. Really, we want to kind of make sure that we know a little bit about the HVAC system that you have potentially in the health center or the health station, to be able to know what kind of filter there is and things like that, to make sure it is safe, again, to have people come in with measles and it's not going to kind of spread throughout the facility. And so if you have questions about anything to do with ventilation or really infection planning in general, infection control planning, it's a really great idea to contact the FNHA team, the IPC team, and I have their email on there, and we'll send it out in the resources as well, because they are the total experts in the infection control plan. And as Emma said, the 2 hours is important. The 2 hours that measles can live in the air and on surfaces is important because even after that person leaves the room, that measles virus will be staying up in the air potentially for those 2 hours. And so we really want to make sure if there's ever a suspected case of measles being brought into the health center, we don't want anyone to be in that room for 2 hours after. And we want to make sure that there's a terminal clean or a really deep clean after those 2 hours are done, just to be sure. And so really looking at that plan in case measles does come to the health center into the community will be good to make sure that it's not spreading within the health center or to other community members that attend there. And then the other piece of this is it could be a good idea to have the front desk people or the people who are welcoming the community members in to be educated on measles, especially if calls start to happen more frequently or there is a kind of increase in need and demand for information. Even having like what's called the health link file or the one pager on measles at the front desk so people can at least be handed that if they have questions. Even having a script or like something that is written out for the front person to say, to be able to say what exactly to do. The nurse will call you back, don't just show up here, sort of thing, to make sure that that is kind of ingrained at the front desk to be able to prevent any exposures as well. Making sure I didn't miss anything there. Perfect. And the next piece is going to be looking at actually your community communicable disease emergency plan. And if that is not something you're familiar with, that's okay. It's just it's a really good idea to kind of think about in these times where we're not having the cases, where we're not having the outbreaks, to think about what we would do if that were the case and how would we work together to prevent cases as a whole in community. And so we know that there will be an increased need for health services if that occurs. We know that there may be increased need for people and for even financial things to help out with some of the supports, and for also material resources like masks and like cleaning supplies and things like that. So really thinking about all those pieces. This really does just kind of look at, does your nurse, do you have a nurse? Are they operating at full capacity? Do they know the immunization rates? Are they able to immunize? Do we have a plan to immunize? It kind of goes back to the things that we're already talking about around those pieces, but ensuring that we have the N95 mask, ensuring that we have cleaning supplies, and ensuring that we know that this work, if this were to happen, does kind of it's immediate, it's an emergency. And so looking at what kind of things would we have to postpone, or what is our essential programming that we would need to continue during this time, and maybe what can we put on pause or offer in a different way to make it safer and also to create more time to respond to this sort of event. And so looking at that plan is a really good idea. And if you haven't seen it before, this is some of the resources that came out early, I think 2020, actually, about communicable disease emergency planning with FNHA. And I serve as the communicable disease emergency nurse advisor. And so I would be really happy if you have questions around emergency planning, or you don't know where to start around that, or you want kind of like an orientation around that. I'd be really happy to connect with you and start to look at some of those pieces, because while it's not solely on the health director or the nurse to create this plan, you will have a big part of it being being in the health center there. And so really just encouraging people to connect back with that and to connect with me if that does resonate with you. And I'm going to pass it back to Emma for the last few slides here.
Tool's been tested on over 6,000 patients, and it's actually been better.
So measles is considered reportable under the Public Health Act in BC. What this means is when someone is identified with the disease, the regional health authority has legal authority to follow up with them and the exposed context to ensure care and direction is provided. Within this process, the person infected with measles is considered a case, and they can spread measles from 4 days before rash starts to 4 days after. A contact is someone who has been exposed to measles, and the regional health authority helps to do this investigation. If they are deemed to be not immune, and if they don't become vaccinated in this process, then they need to stay away from others for 21 days. People around a contact are not at risk unless the contact becomes a case. I can hear radio too. Sorry. I'm just going to make sure this isn't something crazy on my computer that's doing this. I don't know.
I thought I was losing it. I was looking at my phones and I'm looking at the screen. I said, what's going on here? I hear music.
I know I can hear this too, and I'm like, oh my gosh, is this me? I didn't have the radio on, guys, but crazy things sometimes happen. I don't know how to get this to shut off. I mean, it's not bad music, but it's kind of distracting from what we're doing here. So, it's gone now, Megan?
It's gone, I think.
Okay, I don't know what was going on. Sorry, guys. Sorry for that distraction. So, this is what happens if you're a measles contact. So, this is something that people are always quite concerned about. And anyone who has protection to measles infection can continue to live their regular activities. Anyone who is exposed and who does not have protection to measles, if they're a contact, they'll be called by a public health nurse. So that'll either be someone from the regional health authority or your community health nurse might be partnering with the regional health authority and might be helping with this. They may need to get the vaccine quite quickly or immune globulin treatment to help prevent the disease. And like I said before, if they're unprotected and they don't get the vaccine or the immune globulin, then they would need to stay home for 21 days after their last exposure. And then everyone exposed needs to watch for a fever, cough, rash, and to call the health center if symptoms appear. The key to this is that what happens is people get really worried about this situation, and then you get people that are like, well, I was in contact with this person who was in contact with this person. And so how we sort of teach to prevent like mass panic happening is that people who are contacts who are being followed, they will be talked to by a nurse. And so if you haven't been talked to by a nurse, then you're not a contact. And this is something that can be really good upfront education in your community and conversations that you can be having is answer your phones and talk to the nurses. Sometimes they ask questions that you're like, why are you asking me that question? These questions feel kind of invasive. It can feel like they're asking things that are quite private, like how long were you with this person? What were you doing with them? Those types of things. And it's not because the nurses want to be nosy or want to know all of their business. It's that they want to be able to offer them vaccination or immune globulin if they need to, and to help prevent the disease from spreading to other people. And so we know that like Megan said, there's been a lot of really poor interactions with healthcare throughout the history of many individuals or families or communities. And so a really good thing to do is to maybe have an information session about measles where your nurse goes through, these are types of questions that you might be asked if you get a phone call from the regional health authority or from me. This is what you could expect to try to bring that anxiety down. And then encouraging people, if they don't have phones, to have a way to be contacted. Do they have a neighbor who can come and get them and say, hey, like, we need you to talk to these people. What does that look like in your community? If you don't have cell service, do people have landlines? Just going through those situations, because the contacts of contacts of contacts is where people get really anxious and they're like, well, I think that maybe I need to be talked to, but I'm not being talked to. So this is a good conversation to be having. So the next thing is confidentiality and how we can work through that. So BC has the Personal Information Protection Act. Federal and provincial legislation require those with access to personal health information to maintain privacy and confidentiality. It also is mandated to disclose information to appropriate authority if there is risk. Risk could be a child needs protection, concerns about a client's fitness to drive, persons receiving care with certain communicable diseases, and the duty to report is mandatory in these circumstances, even though the information reported may be considered confidential. And so one thing that we talk about a lot within healthcare and within nursing is the circle of care. The circle of care includes healthcare providers and professionals treating a person receiving care. Consent to share information with providers is generally implied, and people who do not fall within the circle of care are family, friends, police, and health directors as some examples. So this means that that we will not provide additional information even when a mother, aunt, uncle knows a certain piece of information already. And we can provide general information, explain relationship reasons, etc. And we can provide de-identified or aggregate data if this is needed for operational planning. De-identified is data without people's personal identifiers, ensuring that individual clients cannot be identified. Aggregate data is summarized data that provides insights on trends, on service utilization, or community health indicators without revealing specific client information. So we're just going to go through a few scenarios about confidentiality just because this is one that gets really tricky. It's hard in small communities, and it's also hard when you're worried about the community and you just want to provide the best service and the best protection to community members. So hopefully these can help with understanding the importance of confidentiality and how to navigate being confidential, but also having enough information to do your jobs as the health director. So a reportable respiratory communicable disease is spreading through your community. Food hampers need to be delivered to a number of homes. How should the health center or nursing station staff go about completing this task? A, the nurse should do it themselves to ensure that other people who are not involved in care do not know who is affected by the communicable disease. B, the nurse is not superhuman. He or she should ask one of the support staff in the health center to deliver the food hamper. Or C, have the nurse phone the home where the food is to be delivered and obtain verbal consent that the support staff will be given appropriate details of the situation for safety and will be delivering a food hamper. So the answer to this one is C. Phoning and obtaining consent is really important in these situations, so that the community knows that when the health center knows their information, when the nurse knows that they, in this situation, have a respiratory communicable disease, that it's not that the whole health center knows exactly what's going on. It's that the person coming to deliver the food knows that maybe they need to wear a mask, maybe they drop it on the doorstep, and that's all they know. They don't know the specifics of what it is that they have or why they're not able to maybe come to the door or go to the grocery store, but they know how to stay safe and where to deliver it to. And this spirals into all care in the health center. And if we can build the trust with the community that everyone in the health center doesn't know if you come in and have a pregnancy test, or if you come in and are tested for a sexually transmitted infection, or if maybe you have a really scary diagnosis that's not contagious, but that you need to be seeing the nurse for or the doctor for. It's not spread throughout the health center. It's not just that everybody knows it. So that's why we highlight this one, so that they know, yes, there's people involved in the care, but they don't know everything about the care. They don't know the specific details. So we have one more scenario for this. So this one is you, the health director, have overheard staff talking about measles that is circulating within the community. You approach the nurse and ask for a list of everyone in the community who currently has measles. A, the nurse explains to you, the health director, that they cannot provide you with names, however, they can provide you with a number. B, you tell the nurse that you are the supervisor and the nurse gives you the list of names. Or C, the nurse explains to you, the health director, that they cannot provide any detailed information to you due to confidentiality. So the answer for this one is A, that the nurse can give you a number, but they can't give you the names. So this could be important for planning, for knowing if maybe you need to have extra staff on hand, or if you need to have extra supplies, maybe you need extra cleaning supplies, or you need extra masks or gowns, or you need to have someone go get some testing supplies for the health center. Maybe you're in meetings with the band council and you're making plans for the whole community, how to navigate the situation. Knowing numbers could be really helpful, but not the names. So that is the situation for confidentiality. That's a very like condensed version, and sometimes it's a big conversation around confidentiality. But just wanting to highlight that trust is what is going to build for all of these situations and all of your day-to-day health situations that aren't necessarily measles related. And I'm just going to pass back to Megan now to finish off the formal presenting portion of this.
Thanks, Emma. And yeah, this page is really just to highlight a lot of the things that we've already talked about and kind of summarize where we started, where we are. And it really was not to scare you. I hope it didn't scare you, but just inform that there is the risk that's going on around us and that could potentially come in. And we just want to make sure we're taking everything we know now to be able to prevent that from happening. And really just being aware that measles cases are on the rise is a good start. Being prepared to take action to protect the community, as well as communicating with the community to help spread the awareness and to know where to find that good information to do some supports. And we even got a few recommendations in the chat today about communication resources that are maybe needed still, and we'll take that as well. And thank you for that feedback, everyone. And really, again, just to remind you that vaccination is the best protection against measles. And it's great that we have time right now to focus on increasing immunization rates and protecting staff and community members from this illness. But also knowing and planning in case for cases and outbreaks is also going to be really important to stop spread sooner, and to think about that infection control plan and to keep those essential services going. And lastly, just really understanding how community is cared for when it comes to measles, how that process works with the regional health authority because of that legality. And it is a reportable illness, so we're going to be working with them, but how do we work together in a good way? And so hopefully that has been helpful. And I know we've missed some questions in the chat already, but I am going to open it up as well to the group. If people do want to come off mic, you're welcome to. And if you want to put another question in the chat, we welcome that as well. MIC, you unmuted there. Do you have the chat open with some questions there?
I do have the chat open here.
Okay.
So I'm just going to scroll up to where we last talked about things in the chat. So as far as the the question about immunization for immigrants. I don't specifically have the exact answer for that. I know there is an immunization schedule for people who have immigrated to BC, but I'm not sure on the requirements, if it's only optional or if it is mandatory. So that is something that I would recommend. You can email the immunization team directly, or you can have your nurse email the immunization team to get that question answered. We can pop the email for that team below your comment there. It's a really good question, just because that is something that in various parts of the province is a reality, that there's a lot of new people around that haven't been following the immunization schedules that people who have been in British Columbia for a long time have. And I did answer the question in the chat about the measles posters. So there was just a question saying that the measles posters focus on recognizing symptoms instead of specifically on vaccination. So right now, as we were chatting, I did get a reply to one of our emails about poster development. So we do have one in the works that we're hoping will be approved and ready to circulate, hopefully this week. So thank you for that. And I will also make note of the request to have the contact information be put on a poster as well. I think that's a really good suggestion. We don't have that in poster form, but we can definitely look at that. And then the question on, can communities carry immune globulin? No, they can't. It needs to be administered in a hospital setting. So in our presentation that we did last week or the week before, I'm losing track of days, but to the nurses, we did share a list of where immune globulin is located in the province, and really encouraged nurses to look at that list and to know what the closest hospital is to them that would carry it, and then to have a plan for how they would need to get a community member to that. It is rare that somebody would need immune globulin, but it is still a good idea to have a plan of how would you transport someone, who would be the transportation person, how would you clean after the transportation. All of that stuff is important things to talk through before you might be in that situation. Is it mandatory for all health staff to be immunized for measles? No, it's not mandatory, but what people need to understand is if they're exposed to measles in the workplace and they're not vaccinated, then they'll need to stay home for that 21 days to make sure that they aren't going to get measles and then pass it on to other people. What could we do if we do not have a health center or community nurse to find out who is or isn't immunized? I don't have the specific answer to that, but I do know that the CIS team is able to work with you on that. So I think that we can pop the email in there and you can email them directly and just explain your situation, that you don't have a nurse, and figure out if they will support you in figuring out who needs to be vaccinated, or it may end up being that it's more of a communication to the community that you don't have a nurse and you aren't able to immunize within your community, but you're supporting people to go to the nearest immunization location, or there could be an opportunity to work with the regional health authority that's closest to you and see if their nurses could come to your community for maybe 1 day or maybe 2 days and do an immunization catch-up. So I'll just pause and see if there's anyone else who has any questions or comments. Megan, if you have anything else that you wanted to add to those questions.
I think you answered beautifully. Yeah, I didn't know the things that you didn't know too. So I think it's going to be, some things are going to be play it by ear and case by case, but we will send out the emails to connect with as well. I just don't have them memorized, so I'll pull those up and get them in the chat to you right here, and we'll also send them out to have some opportunities to connect about those specific situations that are still a little bit unclear. So thanks, Emma. And if we're no more questions, I don't think, feel free to interrupt me if there is someone still wanting to ask a question, but we just really want to take the time to thank you all for being here and for listening to us talk about measles, and we hope it's been helpful, and we would love to hear from you if you want to connect more. So feel free to reach out to us, especially around the community communicable disease emergency planning. Would love to chat with you about that if you're interested. And so feel free, we'll get back to you and be back in touch about posters, and hopefully make sure that those are communicated to you as well. Shelley, I see your hand up. Go ahead.
Yeah, just a question about employers and thinking about, we were just talking here saying that, if we had one person in the organization who maybe brought measles to the organization and several of our staff are not vaccinated, this could potentially shut our operations down. Can an employer mandate for staff to have their vaccinations?
That's a really good question. And Emma, correct me if I'm wrong if you have the answer to this, but from my understanding, I believe it can be an employer policy to mandate up-to-date vaccinations. Emma, thumbs up?
Yeah, I'm
Yeah.
I'm pretty sure. Also, and because you guys are like self-governing nations, you're also able to have your own policies and mandates put in place.
Mm-hmm. So that is definitely an option. And yeah, like you said, Shelley, it can be devastating. One person bringing this in it can actually affect a lot of people, and there are some people who can't be vaccinated, and there are some people who won't be vaccinated, and so it's not everyone is going to have that protection in community, and so just knowing that and really taking those steps is really, really important. So thank you, and Marcy, for bringing that question forward. And if no one else has any questions, I think we're gonna close that. I don't know if you want me to pass it back to you, Kimberly, to close us off in a good way. But again, thank you very much for listening to us today.
Thanks, Megan and Emma and everyone for coming out on a Monday. I know we don't often do this Monday, but it's caucus season, which I know you all know. So we wanted to pick a day that wasn't somebody's caucus. So really appreciate everyone being here. I have been sort of keeping track. So I'm hoping that Megan and Emma, you can share the slide deck with us, and then we will get a group email that will go out. So I know there's been asks for slides. There were some handouts that were attached to the meeting invitation. We'll include those. Also, the request for the template for the CD emergency planning plan document, the contact information, all of that kind of stuff that we've been talking about in the chat. We'll package up and get that sent out. Just acknowledging, though, that my distribution list is health directors. Love that there's lots of people on this call who may be other health staff or community nurses or that. So health directors, we can ask you to maybe pass that information along. And if you get missed and you don't hear from us, please feel free always to send an email to fnhda@fnha.ca and just ask me why I didn't do my homework with you, and then I'll get it sent out to you too. So yeah, so just acknowledging that we've been keeping track of all the materials and resources that you've been asking for. And like Megan and Emma said, there's been a couple of really great suggestions for additional resources, which will get sent out when those are ready. So yeah, just thanks again to everyone, and thank you to the team for making the time to come and talk about this important subject. And I think I'm seeing Charlene waving her hand. So go ahead,
Yeah.
Charlene.
So hi, thank you. I clicked on the link that's shared in chat for FNHA, and then I clicked on the link for, oh God, get me out of it. I clicked on the link for, now it won't let me out. I clicked on the link to get the plan you were just talking about. Now it says connecting with FNHA and is asking us to use a password, username and password.
Okay. So
That is,
we'll look at
yeah.
that on the website. Sorry, go ahead, Megan.
Well, I appreciate you bringing that up because I have heard that too. If you exit that thing without putting in a password, I think it should pop up. But to be safe, we will send
Um,
just the PDF copies of
Okay, because
them
it
as well.
keeps, sorry, it keeps, I do click the X and I click the cancel and it
Oh
says
no.
Windows security. I can't even get, yeah, I have to shut my whole computer down now to get out of this. It won't even let me get on another page.
Thank you for bringing that forward. Yeah, I've heard that that's been an issue on one of the guides on the site. And so we will send out the hard copy just on the email so you won't have that issue.
Thank
I'm
you.
sorry that you are.
Thank you. It's better we work it out here while we're all
Yeah,
still here. That's like, don't be sorry.
thank
It's
you.
teamwork. We get the job done.
That's right.
Thanks for flagging that, Charlene. Yeah, so we'll get that kind of sent out, and yeah, get extra little piece of homework and maybe send a little note off to um whoever in IT is in charge of the websites. It's good when if you ever do, just on that note, find something on a FNHA or even on our website that doesn't link, let us know, because sometimes I'm logged on to the FNHA like as an internal user. And so there might be doors that open for me that don't open for you. But if the door is meant for you and you can't get in, then please let us know. So yeah. With that, I don't think there's anything else in the chat. And for anyone who I left sitting in the waiting room for an extra second, I apologize for that. It's fast and furious for a while. And yes, thank you all very much for being here. Happy Monday. And we'll see you all along the way.